Hello everyone. Now today we will be discussing about the continuation of our previous lecture of nephrotic syndrome, where we have discussed about the pathophysiology and little about the edema and what are the clinical features of nephrotic syndrome. Okay, now let's come to the point of what are the causes, what are the that glomerular damage that has led to nephrotic syndrome. And among the causes, if we remember, then I have talked to you about minimal change disease, then focal segmental glomerulosclerosis, then membranous nephropathy, then amyloidosis, diabetic nephropathy, and the two other causes like membranoproliferative glomerulonephritis and diffuse proliferative glomerulonephritis. Okay, so now let's discuss one by one, and we will able to understand it and able to match the question by dealing with the scenario will be nephrotic syndrome, but they are not going to ask you just nephrotic syndrome. They are going to deep inside it and going to ask you about the which type of glomerular damage is there, and that you have to understand and that you have to remember by knowing all the features of the causes in detail. Okay, now let's move to the minimal change disease. When we are talking about the minimal change disease, you know that the name only indicates that there is a minimal change disease, which means that there is a minimal change in the glomerulus that has led to the nephrotic syndrome. Okay, now while dealing with the filtration barrier, you know that there are three layers, that is the endothelial layer, then glomerular basement membrane and the podocytes, and there are two barriers. One is the size barrier and another is a charge barrier that is responsible for the albumin to remain inside the blood vessels. Okay, now moving to the minimal change disease, it is the most common type of nephrotic syndrome in children that you have to understand. If children presenting with nephrotic syndrome, then your first diagnosis, your first presumption should be minimal change disease. Okay, the causes of minimal change disease are often idiopathic, that it may be triggered to recent infection, immunization or immune status, but that is idiopathic and it is not more nothing new. But the thing that you have to remember is this can be occurred to secondary to the lymphoma, that is Hodgkin lymphoma. And you know that in Hodgkin lymphoma there is a RS cell, ready instant blood cell, and that is responsible for the production of tons of cytokines, and these cytokines cause damage of the layer of the podocyte and responsible for your minimal change disease. What actually happens that if this is your glomerular basement membrane, then the podocyte, there will be the effacement of the podocyte. Look, normal podocyte is this podocyte. This is your epithelial layer. Now, if they will get effaced, okay, effacement of your, it will get flattened, it will get effaced. Then this is due to the damage of your cytokine. The cytokine has leads to the effacement of the podocytes, and because of that, now charge barrier has been lost. And since charge barrier has been lost, there will be leak of the albumin. So there will be selective albuminuria. You are understanding this? They are talking about the damage of the charge barrier, and so you know that albumin is size enough to pass through the pores that is present in the kidney. It is only the charge barrier that was repelling it and keeping into the blood. But now since charge barrier is damaged due to this cytokine mediated damage, now albumin will leak out into the urine, and so that there will be the selective albuminuria or say hypoalbuminemia will be there, but other immunoglobulins will be not lost in minimal change disease. Okay, that you have to be clear. After understanding this, then this we can differentiate in the light microscope, immunofluorescence and electron microscope. Since we are talking about the light microscope, there will be a normal glomerulus. Since it is a minimal change disease, means minimal change in a glomeruli. So if you examine on the light microscope, then it will be appears normal. Sometimes you may see lipid in the proximal convoluted tubule cell, but that is not important. What is the finding? What is the feature of your minimal change disease? The light microscope finding will be normal glomeruli. Since there is no immune complex deposition, it is only mediated by the cytokine mediated damage, so immunofluorescence will be also negative. But when we go through the higher magnification, that is millions time magnification, then on electron microscope you will see this effacement of the food processes. That is the food processes, that is the epithelial layer now has been flattened. That will be the characteristic finding of the minimal change disease. So you have to remember minimal change disease, normal glomeruli, it can be idiopathic, but more important is secondary to the lymphoma, and that is more important to remember is cytokine mediated damage. And since cytomediated damage causes the effacement of the food process of your porocyte layer, epithelial layer. And if you remember this one, then you will surely diagnose minimal change disease. One important thing is, since the cytokine mediated damage has leads to this porocyte effacement, now you have to remember that if anyhow we can block this cytokine release into the human body, then that can be prevent this effacement of that can prevent the effacement of your porocyte, that can prevent the damage to your porocyte, and that cytokine will be blocked by steroids. The steroids are anti-inflammatory, they block the release of the cytokine will not be knocked out, they will not be released, and this will reverse and will be done. So there will be excellent response to this steroid, and that is very important. If you provide this steroid, the patient will get normal magically. So there is excellent response to steroid. That it is very important for your diagnosis of minimal change disease or say management of your minimal change disease. That you need to understand. Other type of nephrotic syndrome usually do not respond to the steroids. That you have to understand very clearly. Okay, that is a very clear and loud red flag message. Now coming to the focal segmental glomerulosclerosis, there is another cause that is responsible for your nephrotic syndrome, and that is focal segmental glomerulosclerosis. The name indicates a lot of things. Look, they are saying that glomerular sclerosis. So the normal glomeruli has been sclerosis, and the sclerosis has occurred. So sclerosis has been occurred. What is sclerosis? Sclerosis is deposition of dense pink collagen that has led to sclerosis. So glomeruli, in the glomeruli there is a dense pink collagen has been deposited. That you have to understand, and that deposition is segmental. Means if you see the whole glomerulus, and in the glomerulus not all glomeruli are damaged, only the portion, only the segment of your glomeruli is damaged and other are normal. This is normal, this is normal, this is normal, but only this portion, this segment of the glomerulus is damaged. So this is glomerulosclerosis but segmental. Other are normal. Other part of glomerulus are normal, and this is the characteristic finding. Okay, so if you examine a glomerulus, there will be a certain segment that will be sclerosis due to pink deposition of dense pink collagen, but other will be normal. Other will be normal. Only here will be dense deposition of the collagen. So you are getting my point. That is, name indicates a lot of glomerulosclerosis, segmental, and sometimes focal means that even in the segment, this focal area, the particular focal area is involved. So you understood focal segmental glomerulosclerosis, and that has been actually described whole pathogenesis. Okay, the most, if you when we will say that there is a patient by history that there is a focal segmental glomerulosclerosis, one you can say it by the examination by light microscope, immunofluorescence, and electron microscope. Mainly the light microscope finding. Light microscope finding will be segmental sclerosis, hydrolysis on H&E stain, that is the pink stain. Immunofluorescence, since there is no immune complex deposition, so it will be negative. Sometimes there may be some non-specific deposit, but you don't have to remember for USMLE. You just remember immunofluorescence is negative. Okay. Now coming to the electron microscope. The electron microscope is the same finding as that of the minimal change disease, that there is the effacement of the food processes like minimal change disease. It has cytokine mediated damage, but here the damage is different. And if you want to remember, then if the patient is progressed from minimal change disease, then it will progress to your focal segmental glomerulosclerosis. Means the finding in electron microscope will be same. Although light microscope there will be normal glomeruli, but here will be a focal segmental glomerulosclerosis, sclerosis of the segmental part of your glomeruli. Thereby you can differentiate between these two also, and you have to remember that effacement of the food process will be present in focal segmental glomerulosclerosis on electron microscope. Okay. Now, what are the clinical points that will help you to diagnose? You have to remember this is the most common cause of nephrotic syndrome in Africans and Americans. Is African Americans and Hispanics. So if anybody is saying that there is a African Americans came to you you should have a ringing in your mind. Okay, they are talking about focal segmental glomerulosclerosis. If somebody is thinking that okay, we are talking nephrotic syndrome in children, then there should be a ringing in mind that okay, we are talking about the minimal change stages, or the question is leading towards the minimal change stages. Although the question will not ask you what is the diagnosis, because there will be a second or third degree question always in USMLE, most of the case. Okay, so the most common cause of nephrotic syndrome, if they are talking about African American or Hispanics, then you have to think okay, we are talking about focal segmental glomerulosclerosis. Okay, idiopathic, there is nothing much interesting, that we know that all the nephrotic syndrome can be idiopathic, the cause is known. Okay, but secondary to other conditions, like if a patient, HIV patient, like HIV infection, heroin abuse, sickle cell disease, massive obesity, interferon treatment, chronic kidney disease due to congenital malformation, these all are the portion in which if there is a nephrotic syndrome, then you have to think for focal segmental glomerulosclerosis. HIV patient came in your clinic, there is the features of all this nephrotic syndrome, that is the generalized edema. Okay, you are understanding the point, all the features of nephrotic syndrome, and if he is HIV patient, your diagnosis should be focal segmental glomerulosclerosis. If he is a patient who is saying that he is giving the history of heroin abuse and developed nephrotic syndrome, your diagnosis should be focal segmental glomerulosclerosis. Okay, if they are talking about sickle cell disease, if there is a massive obesity, interferon treatment, or chronic kidney disease, congenital malformation, if that patient is developing nephrotic syndrome, then your diagnosis should be focal segmental glomerulosclerosis, and that will be evident by all your light microscopic finding, or they will ask you about this finding. That is all about USMLE questions, and you will be able to manage it. Okay, if you are not going to treat, this is not responding to the steroid mainly, and so they may progress to chronic renal failure. Okay, so now let's end this video over here, and we'll discuss about other causes of your nephrotic syndrome in next lecture. Thank you.